acute care and inpatient rehabilitation. So a brief overview. My patient presented to the emergency department on March 17th with signs and symptoms of dizziness, vertigo, difficulty ambulating, and just some complaints of generalized weakness. He was admitted onto the acute care floor from March 17th to March 19th and transitioned into the inpatient rehab unit on the same in the same hospital from March 19th to March 30th. And during both his acute care and inpatient rehab stays, he was also receiving occupational and speech therapy services as well. So my patient had a CVA in his pons, so a brief overview of a pontine CVA. The pons connects the medulla and the midbrain. It transmits signals to and from other structures in the brain and is involved in pace, sensation, hearing, and balance. We also have cranial nerves 5 through 8 located in the pons. So perhaps he had a little bit of involvement of cranial nerve 8, but by the time I saw him for his acute care evaluation, all signs and symptoms of dizziness and vertigo had been resolved. You also have your corticospinal and corticobulbar tracts that run through the pons, and these control voluntary movements of both upper and lower extremity contralateral limbs. So the purpose of this case is to utilize the ICF model to guide clinical reasoning for a patient who provided a unique learning experience throughout the course of treatment. So his examination findings that I'm going to go over were the same for both acute care and inpatient rehab. These evals were only a day apart, so he hadn't really had that much changes when I saw him both times. So he had some right mild-sided weakness, decreased right-sided coordination, right upper extremity more involved than the right lower extremity. He had impaired cognition, so he had some decreased safety awareness and a little bit, he was decreased awareness of his deficits. Difficulty with transfers, gait abnormalities, such as ataxia, short step length on the right, short stance time on the right, and short step length on the left. He took very small shuffling steps, very unsteady, very uneven cadence, decreased weight bearing on the right, decreased weight shift on the right, and then he had a lot of knee hyperextension and some occasional buckling in the right lower extremity. He had decreased endurance. He was not able to walk even 50 feet on the day of the acute care evaluation. And his bird balance scale for his impaired balance was a 23 out of 56, so he was a high fall risk. The neurology section of the APTA actually analyzed some outcome measures to use with CVA specifically. And they recommend the bird balance scale as a level 3 out of 4 evidence for acute care and a level 4 out of 4 evidence for inpatient rehab. So this is one of the reasons that I chose to use the bird balance scale, because I felt like he was going to be a good candidate for us to refer to inpatient rehab. I also want to touch quickly on some of the differences in acute care and inpatient rehab when you do an examination. In acute care, you have a significantly less amount of time. You typically have maybe 30 minutes at the most, and your priority is even more functional than it is in inpatient rehab, because you're just, can I get them home or can I get them to the next level of rehab, because they can't stay at the hospital forever. So we kind of looked at it as, what can we do to provide him with a thorough examination that would get him the referral and the approval to get into the inpatient rehab unit. So I didn't want to just put him on a walker and have him walk 150 feet and then he get denied from inpatient rehab, because I had seen several patients that happened to while I was there. So just a quick review of the bird balance scale. The norm is a 55 out of 56 for a healthy aged older adult with no comorbidities. It tests both static balance and assesses fall risk. So it looks at sitting balance and standing balance. Some things such as just standing with your eyes closed, standing with your eyes open, standing in tandem, picking something up off the floor. And then looking at the FIM, which was the main functional outcome measure that I used in inpatient rehab, varying from a 7, completely independent, to a 1, where they're dependent or need a 2-person assist. And a FIM was looking back at the outcome measures that the APTA evaluated. It is the 4 out of 4 level evidence to use in inpatient rehab. So looking a little bit closer at his FIM scores on admission, for transfers, he was requiring moderate assist or 50% assist, putting him at a 3 for all transfers. For ambulation, he was at 2. He did need moderate assist to ambulate with a rolling walker, and he was completely independent prior to his CVA, but he was not yet able to walk the 150 feet even the day of the inpatient rehab eval. We didn't test any wheelchair mobility. We didn't feel like this was something that he would need after, and we didn't want to limit him in any way. So we wanted to focus on ambulation. And then for stairs, he was a 3. He could do 12 stairs, but he did need moderate or 50% assist. And I didn't test the bird balance scale again during inpatient rehab because it had only been 1 day and I didn't feel like he would really have any significant changes. So when I did the evaluation, I used the ICF model to kind of help gather my thoughts. His health condition was an acute non-hemorrhagic infarct in his left hemipons with notable advanced atherosclerosis of his basilar artery. And then he also, in addition to that, had previously been diagnosed with hypertension and dyslipidemia, which he wasn't being medicated for prior to the CVA. His impairments include impaired balance, mild right-sided weakness, decreased right upper extremity and lower extremity coordination, and an abnormal gait pattern that was mainly ataxic. His activities include singing and walking. His participation, he is a singer, he's very active in his church and in the choir, and a walker. He and his wife enjoyed going on walks, and that was how they got their exercise. His environment, he had 3 stairs to enter with bilateral handrails, and then once he got inside, everything was on 1 story. And he was retiring at the end of the month, like even prior to the CVA, so he would no longer have like a work environment because he just moved that up. And then his personal factors, he's 68, he was a husband, a father, an employee, a grandfather, and then he was a veteran. He's retired from the Navy. Oh, and then his primary impairment was impaired balance. That's what I'm saying. So his diagnosis, he's decreased independence with functional transfers and mobility, secondary to impaired balance. So he was unable to walk and navigate stairs and transfer due to his poor balance. So I felt like he had an excellent rehabilitation prognosis. He had several positive prognostic factors, including his strong family support. He was very motivated, and aside from the hypertension and the dyslipidemia prior to the CVA, he was healthy, and then he was fairly active prior to his CVA as well. But he did have some negative prognostic factors, including the atherosclerosis of the basilar artery that was already present, his age, because he was over 65, and then the dyslipidemia and the hypertension that he already had. So looking a little bit at his plan of care, when he was in acute care, the frequency was having PT 7 days a week, as this was a CVA protocol at the hospital. The duration was just until a bed was available or he got accepted into the inpatient rehab unit, whichever came first. And the intervention plan focused on gait training, transfer training, and patient and family education, which I'll get into in a minute. And his expected outcome was to move to an inpatient rehab unit, preferably the one that was in-house, because his wife also worked at the hospital. So since I did feel like he was an appropriate referral for inpatient rehab, we actually made sure we included specific balance testing in his evaluation, and actually took our findings to the rehab MD and kind of advocated for our patient on this is why we think he would be a good candidate for IPR, because she was a little bit pickier because it's a smaller IPR unit. And I was glad that she accepted it. So his plan of care for an inpatient rehab, was to receive therapy services 6 days a week for the 3 hours that is typical of inpatient rehab. And his speech and cognition actually got so much better that they decreased their frequency, and we were able to pick up a little bit more time with him every day, which he was very thankful for. I set his goals for 2.5 weeks, and he stayed for that amount of time. And for interventions, we focused on balance training, gait training, stair training, transfer training, and then some strengthening, which I'll get into in a moment. And his expected outcome was to be on a supervision and modified independence level, so a 5 and a 6 on the FIM respectively. So going back to acute care, he only had 1 day of actual treatment in acute care before he transitioned. They got all the authorization pretty quickly from his insurance. So we started with just gait training with a rolling walker in order to maximize safety and promote independence. So that way he could safely get up and move as he pleased, even with the nurses and the techs when PT wasn't there. We also worked on transfer training so he could get out of bed and get up with the nurses. We also focused a lot on patient and family education. We talked about like what was a CVA and what would CVA recovery look like, what the role of PT was, and what his PT plan of care would be. And then we also educated him a lot on what further therapy options were available. What did it mean to go to inpatient rehab versus a SNF versus home health, and what could he gain from each of those settings? So inpatient rehab interventions, as his primary impairment was balance, I worked a lot on this. We did some backwards walking, we worked on side stepping, alternate step ups, and like stepping forward to imitate like different phases of gait, such as Vincent. My progression for all of these, we started at first either with the high-low table up high, so we had 2 upper extremity supporter and the parallel bars, and then as we both gained confidence in him, I gained confidence in him, he gained confidence in himself, we backed off to using 1 upper extremity, and by the end we were using no upper extremities. We did some functional strengthening, so we did some heel raises, toe raises, hamstring curls, and mini squats, and marching on foam. And again, similar progression to the 2 upper extremities to 1 to none. And then we progressed the squats and marching to putting him on the RX foam and challenging both balance and strength a little bit at the same time. I have another slide on gait training, so I'll go into detail on that in a moment. We also worked on transfer training, so we worked on sit to stands both with and without upper extremities, and bed to chair transfers both with and without upper extremities. We also worked on car transfer training, and had his wife bring in their personal car and just kind of practice that and go over that so there would be no surprises when they went home. They would feel confident. We did some kinesio taping, which I'll get into in a moment. And then we worked on floor to stand transfers. Prior to his CVA, he was a maintenance worker. So he kind of admitted to us, like, yeah, if something broke at our house, like the sink broke, I would get on the floor and I would be the one to fix it. So this was a salient position for him and had meaning. And he had grandchildren, so he would often find himself on the floor. So we practiced some of that to get his confidence like increased for that. He would feel comfortable playing on the floor with his grandchildren. And then we worked on the transition between tall kneeling and half kneeling, and really trying to get like the glute med activation in the right, because he was still struggling with that. So a little bit more about the gait training. So we focused first on just increasing distance and improving that gait pattern, trying to make it a little bit less ataxic. And we started first with the rolling walker, and once he reached that appropriate distance, 150 is magic number for the FIM, and his gait pattern and balance began to improve due to all the other interventions that we were also doing in addition to gait training. We moved to a cane and implemented that both inside, and then we moved outside using both the rolling walker and the cane outside on grassy, uneven, and outdoor surfaces. And then eventually, his last few days, we progressed to no assistive device within the hallways of the hospital. However, on discharge, we did recommend that he use a rolling walker because he was still having a little bit of that hyperextension and buckling in the right leg. And we just felt that no matter what, if somebody distracted him or he stopped thinking about that right leg for a moment, that he would be able to save his balance with the walker. So I felt comfortable with him being alone during the day with that. And I knew he had additional therapy that they could help him transition over to the cane safely. So interventions for gait training, all about function, of course. So I found an article that really looked at the gait training for patients following a CVA and treatment that focused specifically on the functional task. They needed less time and got better faster. And interventions that focused on impairments like range of motion, they increased their range of motion but continued to have difficulty with their functional tasks. So even though he was slightly weaker on the right side, I didn't really feel like it was appropriate for us to use our time in therapy to lay on the mat and just do supine TheraX. I wanted to do more of the gait training and transfers and stairs during our time together to make it more skilled. And he was very motivated and was always asking, what can I do on my own? So I printed out a few exercises that were safe for him to do in his bed or in the chair in his room and at night to continue strengthening his right leg. So the other intervention I want to touch on is we actually did some kinesiotaping. When I was looking up research for how to, for what I could do with this patient, I found this study that kinesiotape patients' knees, posterior knees, after a CVA. They did a pre-test to evaluate cadence, gait, velocity, step length, stride length, and balance. The placebo group had the same taping. They just did not use elastic tape. And then for the experimental group that did have the elastic tape, they had statistically significant differences, so an improvement, velocity, step length, stride length, and dynamic balance. However, this study, the patients were 3 to 6 months out of their stroke, and my patient was obviously a little bit closer than that. And the study touched on talking about trying to decrease pain, and my patient didn't have any pain, so it wasn't exactly the same. But it did mention the effects of taping on just providing some proprioceptive and sensation feedback to try to get his attention to think about that right leg and reestablishing those pathways that have been damaged by the CVA. So this is this is my brother, but this is the technique that I use to tape his leg. So on the we taped every single day until the last day. I was like, well, let's just try it without it. Let's see what it looks like. Because is it feasible for you to tape your leg every day for the rest of your life, or as long as you are recovering from the stroke, which could take up to a year, maybe not. So we didn't tape, and we were just walking inside with the walker, and I was starting to see some of that buckling and the hyperextension again. So I asked him, I was like, well, do you want me to tape you? And he was like, I would prefer to be taped while I'm, in therapy at least, because it makes me think about that right leg. It brings my attention there and helps me to control it. So any research aside, having that patient feedback, the patient values is part of our EVP triangle. So having that and that he valued that was enough feedback for me to continue to do it. And he went on an outing with the OT and the rec therapist and actually bought a roll of kinesio tape from Walmart. And so I taught him and his wife how to do it and typed up instructions so they could keep doing it. And then he was going to PT after, so I knew they could help him if they had any other questions. Okay. So his discharge status. His transfers, before they were at a 3, so meaning at moderate assist, he increased to a modified independent for all transfers. His ambulation increased from not being able to walk 150 feet and needing mod assist to being at a modified independence level, and this was with the rolling walker. Still didn't test wheelchair mobility, and then for stair navigation, he went from needing modified assistance to being at a supervision level. So and his bird balance scale increased to a 50 out of 56, and as you recall, he was at a 23 out of 56 on his first day. So the MDC for patients who have had a CVA for the bird is an 8.1. So and there's no known MCID, so he clearly met that with flying colors. And according to rehab measures, so 45 out of 56 is the cutoff for being a fall risk after he had a CVA. So I felt pretty good about his improvement there. And then lastly, I found an article that looked at, it predicted in patients who've had a stroke, it took several outcome measures and predicted how well they would be able to be a community ambulator. And the cutoff, which was greater than 0.8 meters per second, and the cutoff for the bird was greater than a 45.6. And he was above that. So this is another variable that made me confident that I was sending him to outpatient therapy because I knew he would be safe ambulating in the community, even when I got to the point that his wife wasn't going with him. And then his wife actually works at the hospital, and I saw her 2 weeks after he discharged, and we asked her how she was doing, and he said he had no falls, he was making excellent gains in outpatient therapy, and they were very pleased with his progress. So that was good to hear from her. So his final home exercise plan, I gave him some more of just the basic strengthening that he could work on, and a little bit of balance that he could continue to do to bridge him over until he followed up with outpatient PT, which is about a week later, and they could update as needed. So I gave him sideline hip abduction, clams, prone hamstring curls, standing heel raises, standing toe raises, standing hamstring curls, and straight leg raises, all with an emphasis on the right leg. We also did 20 anterior step-ups, 20 lateral step-ups, mini squats still on a pillow, and marching on the pillow. So some limitations of my case study. I wish I did incorporate more gait measures, specifically 6-minute walk test and gait speed, because he had such difficulty with that I feel like that would have helped me measure his progress even more. And when I was looking specifically for research on CVAs in the ponds, there wasn't any that was specifically for interventional and rehab out there. It was more just CVAs in general. And a couple of classmates pointed out that maybe my final home exercise plan was not challenging enough because he was already able to do it in the clinic. So maybe I didn't challenge him enough if he was at that modified independence level already, and that maybe it was too long. It was kind of overwhelming. It was 6 pages. Is that realistic for him to do every day? He was motivated, so maybe, but I don't know. So those are my references. Any questions?
Could you talk a little bit more about why you didn't have him walk 150 feet with a walker in the beginning?
Because he couldn't do it. He had such poor endurance, and it was a safety issue. His gait was so ataxic that I didn't feel comfortable having him walk any further.
Okay, because I think you said something about you've seen people do that and then not be able to get services.
Right. So sometimes if a patient is that borderline between maybe they could get qualified for IPR, maybe they couldn't. And they are walking that 150 feet with a walker with maybe they were completely independent prior to, then maybe they'll get denied. They'll say, oh no, they can just go home because they can use a walker and be okay. And we are trying to get him off of a walker, even though we don't quite have enough time.
Yeah, that's what I was wondering about. You purposely did it to play a game, benefit the patient.
It's to benefit the patient.
Yeah.
But you have to be careful in acute care. If you walk them 150 feet, oftentimes the third party reviewer will look at that and say, nope, they must that. They just look at the 150, they don't look at quality. That's a consideration.
Yeah, absolutely.
The services that they need.
Which is sad that it has to be that way.
I kept writing down questions, and a sentence later, you would answer them.
Good. Good.
Let's see. In the study that you looked at with the kinesiotaping on the folks with CVA, what types of impairments were they having on their hemiplegic side? Was it more weakness, or were they folks with more spasticity who were snapping in hyperextension?
No, it was more weakness and more hemiplegia.
And you said that he did you qualitatively or objectively see differences in his gait with and without the kinesiotherapy?
Qualitatively, I think it looked a lot better. There wasn't, the ataxia was improved. There was no hyperextension. I think that was necessarily just because we kept walking and we did it with the tape every day, not necessarily that the tape.
No,
Yeah.
Immediately in one session,
yeah.
tape off, tape on, you
Yeah.
see differences.
Just the buckling and the hyperextension.
Help with proprioception.
Mm-hmm.
Yeah. Gait velocity. Tell me about your hospital. Was it a stroke-specific hospital, or how did you get to follow from inpatient?
So the inpatient rehab unit is only 6 beds at this hospital. So the doctor splits her time between Williamsburg and Virginia Beach. So she's very, very picky about who she'll accept because she's not always on site. So since it was so small, if we didn't have a full caseload in IPR, we floated over to help acute care, and he just happened to be on our caseload that day.
So I was wondering, how did you get to see him both acutely and on rehab?
Yeah.
That's kind of a unique opportunity. Use of the rolling walker, you said, was primarily because he had the ataxia?
More the buckling of his knee and the
Okay. So more for the weakness thing. I was going to ask if you thought it was compensatory or mediating, but it really was more for the buckling than the attack. How can you account for his progress from the rolling walker to the cane and then to no device? Was the ataxia or the buckling the big issue? What was changing?
I think the buckling was changing the most. He was getting stronger.
And the ataxia must have changed as well.
Yeah, I think it did. yeah.
You know, you saw him. So,
Yes.
and do you think that got better with reduction of swelling or because he was practicing functional
Yeah, I think it was
tasks,
just more like the practicing the functional tasks and just repeating those pathways that had been damaged in the stroke, more of like the repetition and the plasticity more than any specific intervention.
And were you surprised to see ataxia with the pontine stroke?
No, because it also like the circulation also goes like to the cerebellum, and then your cerebellum and your pons are working